In the spots, this is okay. Should we scoot in?
Yeah,
Can I?
we're recording.
Perfect.
We're recording.
Cool.
Sound
Great.
is coming through.
All right, beautiful.
Awesome.
All right, man.
Well, welcome back, Dr. Greenberg.
Dr. Cotter.
Derm Bros 13. What's new in 2022?
Yeah, it's kind of amazing that we're here. Wait, we got to get ready for the talk, so I'm going to put on my mask, and I'm going to get ready to do my talk.
Actually, I think we need something else to get ready for this talk because the reality is the pandemic is over. It's been over for a while.
Okay.
And while that might have inspired our initial Derm Bros lectures, today we have something else we need to get this party started.
A little champagne.
Time to celebrate that the Derm Bros are back.
Yeah, it's been a long journey. It's been a rough couple of years.
But we're very excited to share with you guys so many new, exciting ventures, both with Las Vegas Dermatology and in the broader house of medicine, dermatology specifically. We're going to talk to you tonight about all the new drugs that have come out in 2022, as well as a charitable.
Yeah, we have a charity that we began in 2022, the Las Vegas Dermatology Foundation. And so we're going to celebrate that. We've already got a $2,500 donation. It's
amazing.
A 501c3. That's right. Las Vegas Dermatology donated to the foundation. In fact, here's the QR code. So if somebody wants to donate, then we're going to talk a little bit more about the foundation.
Yeah, there's a few different charitable missions, and we'll get there in a few minutes.
That's nice.
Wow, excellent work, Dr. Greenberg.
Well, thank you.
I mean,
it's a mess. So these champagne flutes are from they're Murano glass.
Wow, where did you get these?
Well, I was in Venice, and it's a long story, but they're Venetian glass.
I love it.
That's for you.
Beautiful.
It's for me. I hope you at home, anybody who's watching, oh yeah, that'd be good. You can bring that in. I think anyone's at home who's watching can grab a glass yourself.
Cheers. It's 5 o'clock somewhere.
We need a little bit more. I think that'd help. Oh yeah, you can take it. And then we'll bring it back.
Cheers.
Cheers, l'chaim, to 2022. All right. Well, we're going to get started. And we're going to be talking about dermatology updates. And these are the areas in which there are new drugs for dermatology. Oh, keep the champagne close. We're going to need that. Acne, alopecia areata, different cosmetic dermatology drugs, such as Daxxify, which is a new botulinum toxin, and Restylane Kiss.
And we can't forget about our other inflammatory skin diseases. Atopic dermatitis and psoriasis in particular have seen a real revolution in the number and quality of medications that are available to our patients. And we've also seen similar changes in rosacea. And excitingly, we finally have on-label indicated products for vitiligo. So for patients that are suffering from loss of skin pigment, there are new medications that can be highly effective.
Yeah, so we've sort of divided the drugs up between the two of us. And this is just a picture of one of Dr. Cotter's patients.
And just an example of eczema in a young child. And this is a kind of straightforward layup case that we were able to treat just with topicals. But there's plenty of patients that can't get across the finish line, can't get this kind of result with just topical medicines alone. They have hardened eczema. We'll talk about an exciting new development for children in this age range.
That sounds good. So I put this slide out because the paradigm is starting to change in terms of how we're treating these diseases, because a lot of the newer drugs are actually safer than the older drugs that we've used.
Yeah, so I see Dr. Greenberg built a little pyramid here, and it kind of gives you a historical idea of how we used to treat eczema. Turns out systemic steroids, prednisone, is really the only on-label systemic option to treat atopic dermatitis before the advent of some of these newer drugs, Dupixent, Adbry, and oral JAK inhibitors. But he threw in cyclosporin here, which I love, because cyclosporin is a pretty toxic immunosuppressant, but it has been shown in clinical studies to be safer than prednisone, which is the on-label medication. In this day and age, really no patient should be on systemic steroids or something like cyclosporin or other toxic immunosuppressants. We have such great, safe, and effective new medicines that we'll talk about.
Right. And in terms of the other drugs, Dupixent and Adbry are two great new drugs for injectables for eczema. And then the oral JAKs, that's the newest class.
Yeah, the JAK inhibitors are very exciting. We've been watching this family of medications grow up for about 10 years now. And we've all been really excited to see how these little JAK inhibitors are going to grow up, just like you watch any other family. There's little kids, they're playing in the neighborhood, and is Johnny going to be a lawyer? Is Susie going to be a dentist? Is Billy going to, be a car thief? And we don't know. But we've watched these JAKs grow up, and it turns out the JAKs that we use to treat atopic dermatitis are both safe and highly effective.
So we again divided this up into systemic drugs for eczema. So these are systemic options, and Dr. Cotter will review the first one.
I think the most exciting development is that Dupixent, an injectable monoclonal antibody to treat moderate to severe eczema, is now FDA approved down to age 6 months. Personally, here in the practice, Dr. Greenberg and I have both been treating children with eczema as well as adults for many years since it was initially FDA approved. But every single time we had a younger indication, it just meant more of our patients with moderate to severe eczema could get an effective treatment to be able to get relief from their atopic eczema. And now we're treating patients as young as 6 months in the practice. And it really does a pretty dramatic result in terms of improving their eczema scores. Here we're looking at the Dupixent response, and these are the percentage of patients that are becoming clear or almost clear, or having at least a 75% improvement after starting Dupixent. This is after just week 2. 50% of patients are 75% better after just the first dose.
Yeah, it's an impressive drug, and one that we've used a lot in the practice. And now with the new indication, this prurigo nodularis, which I have a patient who has me biopsy and remove his because he's itching at these bumps so much and they won't go away.
Yeah, prurigo nodularis is a really difficult condition for a lot of patients. It's something where you have all these little itchy nodules all over your skin, and it's really characterized by an itch, scratch, itch cycle. And I don't know if you know this dermatology trivia, Dr. Greenberg, but there was this old study done in military medicine, I think in the 1950s, and it was the equivalent of how many licks does it take to get to the center of the Tootsie Pop. But they were asking how many scratches does it take to make lichen simplex chronicus or a lesion like a prurigo. So what would be your guess? Would you wager a guess how many times you have to scratch to actually get an LSC or a prurigo?
I'd probably say 1,000 times.
1,000 times. So it is actually 206,000 times.
Oh my God, that's a lot of scratching.
So for all the patients that are watching, we empathize with you. We understand that you're tired of dealing with this condition because it took a lot of scratches to get to this point. And for all the dermatologists out there watching, please bring empathy to your patients with prurigo and LSC because they're exhausted from scratching. It took 206,000 times to get each individual lesion. So they need a better medication, and Dupixent certainly works well.
I am a speaker for Adbry, which is a Leo drug. This is a drug, an injectable drug, similar to Dupixent in that it's an interleukin inhibitor. And this is an interleukin 13 inhibitor. And this is the interleukin, and this is Adbry. It's a human monoclonal antibody. And what it does is it binds that IL-13 that's circulating in the blood, and it makes it so that it doesn't go down this JAK-STAT pathway that we're going to talk more about later. But it stops that signaling and reduces the opportunity.
So, Dr. Greenberg, how is this medication different than Dupixent?
So Dupixent is a 4/13 inhibitor, so it binds in this area. Does that seem like your area?
Yeah, so they're both injectables, but Adbry's a little more specific to just the one molecule, IL-13.
Mm-hmm. And when they did their studies, I thought one of the important things, and when I'm looking at the data, is how many of the patients were moderate and how many of the patients were severe. So when they chose their patient sub-selection to get the approval, half of their patients were severe and half were moderate. And it's a lot more difficult to treat a severe patient than a moderate patient.
Absolutely. There's more ground to cover.
And this was at 16 weeks and just doing an easy 75 score, so about a 75% improvement. This person was considered not to be a success story, even though they went from severe to mild disease. They had to go to almost clear or clear.
I can tell you what, I think this would probably be a happy patient. If we got this result with one of our patients in the practice, they'd usually be pretty happy. But it's interesting to see that that's considered a treatment failure.
Yeah, and I think it's important to know that. And when they did their studies, they did 2 types of studies. One study they used topical steroids, and one study they didn't use topical steroids. And we still, in our practice, use topical steroids quite frequently.
Absolutely.
So what they showed was that people who had the Adbry versus people who had the placebo, they used less steroid to get to where they needed to be, because they measured, how much product was left when they brought the tubes back in.
It makes sense.
Yeah. Now we didn't do a study for this, but we have done a Dupixent study in the practice.
Yeah, and ongoing.
Yes, we have a couple other studies too. All right.
So I really, in 2022, I like to say derm got jacked. But not this Jack, and it's not that Jack. And this would be kind of cool if this was before treatment and after treatment, but it's not that jacked either. It's this JAK, selective JAK inhibitors. And the first one we're going to talk about tonight is one called Rinvoq, or upadacitinib. It's a small molecule made by AbbVie, and it's really highly effective. It's FDA approved for 5 different indications. Most relevant to us tonight is its utilization in atopic dermatitis, where it's approved down to age 12. It's the only JAK inhibitor right now FDA approved for atopic dermatitis as young as age 12. It works really well. This is an example of a patient, one of the studies, going from a severe eczema score to almost clear. It doesn't matter what type of skin you may have, this drug works really well for you with decreasing thickness of the skin, itch, lichenification, and we're seeing these results right here in our clinical practice with numerous patients on these medicines doing absolutely fantastic. This gives you an idea of how fast it works. So it used to be to give people results this quick in eczema, we had to give them systemic steroids. It'd be that, mom was going to be the maid of honor at her daughter's wedding and she wanted to wear a certain dress, but her eczema was too wild. We'd give her prednisone for a little bit. But now, with a medication like this, we see patients hitting a 90% improvement as early as 4 weeks on drug.
Yeah, I thought this was a super impressive slide, and we both speak for this company. The Easy 90 is just such a high bar.
What that actually means is a 90% improvement. So for any patients that are watching, what this drug can effectively give you is as early as 8 to 12 weeks on medication, you've got a 50 to 60% chance of being 90% clear in your eczema.
Yeah, there you go, Easy 90.
And Blaine is asking, what is the best treatment for 2.5-year-old with moderate eczema?
Yeah, thank you for the question. It really depends on the case specifically, and this wouldn't be medical advice for your little one because it really does require an assessment in office. But usually we start with topical medications just to calm things down, and in the appropriate patient with moderate eczema, if it's really difficult to get under control, I think the next step is adding Dupixent.
Yeah, that's
and
it.
In that age range, depending on the weight, it might be 1 injection every month or 1 injection every 2 weeks. And we've seen a lot of good results in patients of that age.
Yeah, it's really changed our practice having these little kids, and we have a nice staff who's really good at handling kids. So when it comes to injecting children, at first they're scared, and then when they come back after a number of treatments, they do really well.
I remember, meeting with families every 2 weeks, writing out how to use 5 different topical medications, specific ones for specific areas, how often to apply, and it was quite laborious for a lot of these families. They're up around the clock, the baby's not sleeping, they're itching all night, there's blood on the sheets, and they're working really, really hard to get the eczema under control. We still have to do a little bit of that, but with Dupixent injections, it simplified that care for a lot of our families, and Dupixent is very safe. And we feel pretty comfortable using it in most patients.
In this one, Rinvoq is for age 12 and over, so you couldn't use it in that child. I'm a speaker for Pfizer. This is AbbVie's drug. I'm sorry. I'm speaking for Pfizer, and this is Pfizer's drug. This is Cibinqo, and it's 100 milligram. It's abrocitinib. It's either 100 or 200 milligram dose. And this is the JAK pathway. So we saw with the Adbry slide where it was binding the IL-13, and here we're working lower down in the pathway. So it's making it so that this receptor doesn't come together to go to the nucleus and create these cytokines that worsen the disease. Both of the drugs work this way, and here's a slide just showing how bad the patients were. And we talked before about the 50%, and here the patients, 64% were moderate and 36% were severe. And these were in the studies that got the drug approved. And what they found was when they didn't use topical steroids and they were at the higher dose, 62% of the patients got that Easy 75 score.
It's amazing.
Yeah, and this is for patients 18 and over. And I think we should say that even though we both like the JAK inhibitors and the growth and the results are really good, there is monitoring that you have to do. So it's not the type of drug that you can just put somebody on right away.
Yeah, you really should see an expert in this area to make sure that you're being managed appropriately and everything is safe, not just effective.
Yeah. And this just is a study that Pfizer did using Dupixent as one of the arms of the drug, and showing that the patients who were on Dupixent and the 100 milligrams of Cibinqo did just as well at their primary endpoint at 12 weeks, whereas the higher dose, the 200 milligrams, there was a higher percentage of patients who had that Easy 75 score. The thing that I would say about this slide is 12 weeks is kind of early for this disease process for this kind of drug.
Yeah, I can say that I've had a number of patients on Dupixent over the years, probably in the order of hundreds, if not thousands. And most patients do extremely well. But certainly there are folks that don't quite get the skin clearance that they're desiring. And I've switched a number of them over to a JAK inhibitor like Rinvoq or Cibinqo. And it's really incredible to see how those patients who didn't quite get across the finish line on Dupixent really do on a JAK. And I think that if you're out there and you're on Dupixent and you're not at the clearance that you want, it may be something worth considering.
Yep. 100% agreement. And that was just at 16 weeks, just showing that there's continued improvement. But it was a continued improvement across all groups. And this is just showing somebody in that Cibinqo group who was clear. So he started off with these excoriated scaling plaques, and they went away. And this would be a happy patient. We talk about in atopic eczema how itch is the biggest deal to a lot of those patients. And stopping that itch is important.
Yeah, so we call it the itch that rashes, and it really is true. And JAK inhibitors have been shown in clinical trials to be highly effective at decreasing itch at really a immunological molecular level as early as 2 days after the first dose.
So, you'd want to be careful if you're pregnant. These may not be the drugs for you. They haven't been around as long as some of the other drugs we use. So you're going to want to talk to your physician about that. In dermatology, a lot of it is topical, and we use a ton of different creams and topical modalities. So it used to be, for eczema, all we had were topical steroids.
And then we got topical calcineurin inhibitors with tacrolimus and pimecrolimus in the late 90s, early 2000s. Mm-hmm. And then Eucrisa, which was the first available topical PDE4 inhibitor, was FDA approved, I think, just maybe 5 years ago or so.
Yeah, and I loved how Larry came into the office. We love Larry, and was talking about a different drug. The PDE4s are still great drugs, and they do really well. And there's a new PDE4 we're going to talk about later for psoriasis. But the Eucrisa is the topical PDE4 that we use for eczema this time.
And then in the last 24 months or so, we have a new topical medication, FDA approved for atopic dermatitis, as well as vitiligo that we'll talk about, and it's a topical JAK inhibitor.
So yeah, this is the one, Opzelura. I speak for this company, and they have a great drug that the max use is 20% of your body surface with the drug, but when we saw those EASI-75 scores before with the oral drugs, this is a 62% EASI-75 by 8 weeks, so that's really quick onset. You should be aware that if you have a propylene glycol allergy, or if you don't want parabens or a paraben allergy, it may not be the drug for you.
Yeah, it's pretty impressive to see that, particularly the EASI-90 scores, 43% of the patients have an EASI-90 by week 8. What that translates to is 4 out of 10 patients, 2 months into this topical medication alone, have 90% improvement in their eczema.
Yeah, this drug for me has been a game changer. And here they talk about the current AD landscape. Dr. Cotter does a lot of speaking on atopic dermatitis. Atopic
dermatitis is near and dear to my heart. It has been ever since I first learned about it from one of my mentors, Larry Eichenfield at UC San Diego. It's an important disease. We see a lot of it. And I like to tell the medical students, we have a medical student with us this week, that just because you're seeing your 20th atopic dermatitis consult of that day alone, it's still the first time that patient is getting a chance to talk to someone with your level of expertise. And you need to approach it in that way every single time, because it has such a big impact, not just on that individual patient, but the entire family. We know that atopic eczema is more likely to be associated with other diseases, cardiovascular disease, diabetes, fatty liver disease, psychosocial diseases, depression, anxiety, workplace absenteeism, loss of sleep. Yep. It really is a systemic disease that manifests in the skin, and it's really important to treat it effectively.
Right, and some of those people have asthma, allergies. So we do a lot of both patch testing to see if you're allergic to something, and blood work to see if you're allergic to something that you eat or breathe in. And here's a patient who is on Opzelura who went from this baseline of moderate disease to almost clear, and then they remained at almost clear. But when you get to that point, I think this would be a happy patient. This was considered a success because it was a 2-grade improvement. And Here we have psoriasis, and this is me when I was a resident in Texas, and this was the professor, and the professor was on an injectable drug for psoriasis. So we've certainly changed now from injectable, and when I say injectable, I meant an intravenous injectable drug for psoriasis. We're not doing that in our clinic now. We're doing injectables, yes, but not IV drugs.
Yeah, we've come a long way with drug delivery.
And this is for the topical psoriasis options. Again, topical steroids, it's a classic in dermatology. The calcineurin inhibitors, they aren't approved for psoriasis, but they're used in it. And the new class is this aryl hydratase inhibitor, and then a new PDE4 inhibitor for psoriasis. So the new one here is Vtama, and this is tapinarof, and it's a whole new class of drug which has multiple mechanisms of action. And it's a novel science. It's an aryl hydrocarbon. It's a pathway that I didn't even know existed until the drug came out. I don't know, did you know about this before?
I mean, I hate to say it, but I did know about it, Dr. Greenberg.
I know. Doesn't surprise me. There is propylene glycol in this one as well, but there's a couple details to the formulation that make it so that it's an elegant product, and it has a lot of really positive effects, not just on reducing inflammation, but on the skin barrier as well. And skin barrier is really important both in psoriasis and atopic eczema, more so I would say in atopic eczema. But here they're talking about the biologic effects, decreasing the Th17 cytokines, decreasing oxidative stress, and improving the skin barrier. So all very important when it comes to the disease process. And then here, decreasing inflammation. And then the oxidative stress is reduced, so antioxidants, increasing filaggrin, loroquine, and Voleukin, just working on the skin barrier itself. And right now, it's only approved for psoriasis, and that's by decreasing IL-17A and F, and there is a drug we're waiting to have come out that's the IL-17A and F inhibitor.
Stay tuned.
Yeah, we're not yet there, so maybe
round 3 in 2023, if they ever get approval.
Yeah, if they get approval, hopefully they do. And here's, they're working on, the Vtama crew is working on an atopic eczema indication. Not yet there, but there are studies. And here, it's that IL-4/13 that we saw before with the Dupixent and the Adbry.
I think what we're seeing over and over again tonight with these new drugs is really a revolution in the way that we target cutaneous disease. It's really a molecular immunologic underpinning approach. We understand what causes these diseases, the specific molecules that are dysregulated, and we're fortunate to have medications that can turn the volume back down, right? If your signal's way too high in IL-4, we're going to turn it back down. If it's way too high in IL-17, we're going to turn it back down. So I like to think about these as modulating dysregulated immunology.
Yeah, and they're going to show as we move forward with the company's slides that even after you stop it, because you've changed that regulation, when you come off the drug, your body has changed to the point that you're not going to have the disease process for months afterward, which is pretty cool. In terms of the physician's global assessment, 35% of these patients were considered clear or almost clear, and then 42% in the next group. And this is a patient with psoriasis, the silver-scaled plaques on erythematous base, just clearing up over time, and their PASI score was a 0 on the week 12 assessment. And here's somebody, the same thing. This is a physician's global assessment score of 1, so it's almost clear. And this is a really nice result with just a topical cream.
Absolutely.
Yeah, so we've now had some good experience with this drug. Neither of us speak for the company, although we both wish we could.
I mean, why wouldn't you want to promote something that works and is safe and effective?
Yeah, there's no there's no black box for this drug, so there's nothing that has come up as a signal, which is really nice. It's not like that for every drug. And here is showing that 4 months off treatment, there's this remittive effect. At least 25% of people were clear, almost clear at 222 days. So half of those people at 115 days.
That's extremely remarkable. And what this means is patients put a cream on their skin until their psoriasis went away. Then they stopped it, and their psoriasis stayed gone for quite a long amount of time. We don't see this with topical steroids. We don't see this with other medications. It's fantastic.
Yeah, it's just altering the disease pathway, which is really cool. And here is just their psoriasis long-term extension, 48 weeks, and this was off of the drug for 24 weeks. So, going from here to here is going to really change someone's life. I mean, these plaques can be quite upsetting. This disease state, and we should always ask, do you have joint pain when you have this process? Because that would involve adding in other medications, because this is a topical medicine, and you're going to need a systemic drug if you have joint pain.
Dr. Greenberg really likes that medication.
Apparently so.
There's a lot of slides for a cream.
Apparently so.
I'll take this one. So, in the same space, topical medications for psoriasis, we have Zoryve, and the graphic is kind of fun, so we wanted to include that. But this is roflumilast. It's a topical PDE4 inhibitor. Before we had this, in topical land, we had Eucrisa, a topical PDE4 inhibitor, FDA approved for now down to mild atopic dermatitis, down to age 3 months. And then in terms of the psoriasis space, we had an oral PDE4 inhibitor called Otezla or Premolest, which is approved also for mild psoriasis now. This drug is so extremely effective, and the way that it works is it gets into the skin and it affects cyclic AMP metabolism. And by inhibiting PDE4, that's an enzyme, phosphodiesterase, that would normally be breaking down cyclic AMP. And when cyclic AMP decreases, the simplest way to think about it is inflammation goes up, okay? And so as we inhibit that process, that breakdown of that cyclic AMP molecule inside of the cell, it accumulates, and that results in a decreased expression of key pro-inflammatory mediators. And so you'd hypothesize that this would work really, really well, particularly because this drug itself is able to bind to PDE4 25 to 300 times more greatly than Apremilast, which is Otezla, or crisaborole, which is Eucrisa. So we're talking about an extremely potent drug. And let's see how well it works, Doc.
All right, let's see it.
So here's some patient examples illustrating topical use. And I like how they have the timeline, so you can really get an idea of how fast it's going to work. We see big, thick, micaceous, well-demarcated plaques with silvery scale at baseline on this patient's knee. By week 2, he's starting to clear. By week 4, it really looks like there's mild psoriasis left. And by week 6, he's almost clear. By week 8, almost clear as well. It also works well in intertriginous areas. So we know a lot of patients with psoriasis will have it in sensitive spots, underneath the armpits, in the groin creases, in the gluteal cleft. And I'm always a little hesitant to use long-term topical steroids there because I'm worried about thinning the skin, causing stretch marks. And you just don't see that with this medication. What you see is extremely well efficacy. So it's well tolerated and highly effective.
Yeah, and the interesting thing to me about this drug is that they went for the psoriasis indication before the atopic eczema indication.
I agree with Dr. Greenberg. I think that we'll probably see a atopic dermatitis indication down the line, which will be fantastic because this drug, unlike really all of the other non-steroidal topical either psoriasis or atopic dermatitis medications, this drug, as it exists commercially available, doesn't have propylene glycol. So in fact, I wrote it today for a patient with known propylene glycol allergy after patch testing. I said, we discovered you're allergic to propylene glycol today. It makes sense why you're not getting better with these medications. You need Zoryve, and we wrote for it today.
Yeah, I think that patch testing that we do where I had some patches that were normal on Wednesday, but now we're positive on Friday. And that's a real good thing to find out what someone's allergic to. It changes their life forever.
Absolutely. So how well does Zoryve actually work? We showed you some examples, some anecdotes of individual patients, but statistically, how much is plaque psoriasis improved? We're talking about a mean change from baseline in their plaques of about 70% improvement over a 4-week period. So over a month, patients are going to experience a 70% improvement in the severity of their psoriasis, is essentially what we're showing here.
Yeah, that's unbelievable, especially for a topical.
I really like this graphic. This is published in kind of an obscure medical journal. You may or may not have heard of it. It's called the New England Journal of Medicine. Is that one you're familiar with, Dr. Greenberg?
No, never heard of it.
Yeah, I mean, I don't know where they got this from, but in either case, this fantastic graphic pulled out of the New England Journal of Medicine gives you an idea how this drug is, what it's for, and how well it works. They studied 2 different concentrations. The 0.3% was the one that was approved, and it just blew placebo out of the way, with 28% of patients being clear or almost clear on a 5-point scale after the randomized trial.
Yeah, that's great. All right, so systemic drugs and options for psoriasis. When I was training, which was a while back, we were using methotrexate. And methotrexate is a great drug. It works, and a lot of our rheumatology colleagues still use it quite frequently for psoriatic arthritis.
Yeah, I think we see it a lot in that space for joint disease. But I'll tell you what, if you were to do a clinical trial right now for methotrexate as an indication for plaque psoriasis, I bet it wouldn't even get approved.
Probably not. In biologics, we both do some speaking for the interleukins, the IL-23s, the 12-23s, the 17s, the TNF-alpha inhibitors. Those are all biologic drugs for psoriasis. I speak for Premolast, Otezla, Amgen, which is a PDE4 for psoriasis. Nothing to monitor with that.
But for what's new this year, what do we have coming down already in the pipeline?
So there's Tic2, and now there's Sotyktu. So Sotyktu is a pill from BMS, Bristol Myers Squibb, that is a great drug in that with the JAKs, there's some testing we need to do. With this one, it's in the JAK class, but it's a different type of JAK. So you're saying what kind of JAK?
Yeah. What kind of JAK is it, Doc?
Well, it's a nicer JAK.
Yeah. So to give you an idea, Sotyktu works extremely well. About 50% of patients become clear, or almost clear by week 16. When it's on the scalp, we see that in about 70% of patients. I like to kind of analogize this too as an oral version of Humira. Lots of patients with psoriasis have been on that drug in the past. It works about as well as that drug, but as a pill.
Yeah, that's great because a lot of people don't want to take shots. They're scared of needles, and it can be when you're traveling, taking a pill may be easier for you given your disease state.
Let's take a look at what type of JAK this is.
All right.
So in the JAK family, this isn't just a simple JAK. This is a really important JAK. This is an allosteric regulator of TYK2. So in the JAK family, there's JAK1, JAK2, JAK3, and TYK2. And this is a graphic we pulled from a JAD paper I published with Dr. Eichenfield and Dr. David Shire a few years ago when these things were really coming out and hitting the press.
Wait, who's the first author in this?
Oh, yeah, that'd be me.
Okay. Just checking. I just want to see.
And so all of these medications, or all of these enzymes, work by initiating a signal cascade inside of the cell that results in changes in gene expression that manifest as the disease state. And so we're going to talk about how Sotyktu inhibits TYK2. It's kind of a unique mechanism of action. So all of the JAK inhibitors share a kind of common and overlapping active site, and that's what's shown here in blue. These active sites bind a molecule called ATP. That's how they do their business. They utilize that to be able to initiate their downstream signaling. All of the molecules that inhibit the active site would be JAK1 and JAK1, 2, and JAK3 inhibitors, and they bind to the active site. But Sotyktu works in a different way. It binds over here in the pink subunit, which is something called the allosteric domain. So we have Sotyktu coming in and binding it here, and when it binds here, it changes the shape of the active site. So the active site can't bind its ATP, it can't do its business. But what's really cool about that is unlike JAK1, 2, 3, and TYK2, which share a pretty common active site, the allosteric regulator domain is unique to TYK2. So Sotyktu can selectively inhibit just TYK2. It is Sotyktu.
That's pretty cool. All right, well, this one is yours. This one, I was really excited when it first came out because we have a lot of patients who have alopecia areata.
Yeah, I feel like these Derm Bros lectures have been really helpful, not just for us, they've been a lot of fun, but it's been great to connect with patients. I remember back, I think probably in March or April of this year, I had a patient reach out to me on social media, and she asked me, would you prescribe me an oral JAK inhibitor for alopecia? And I said, I'm definitely open to it. Why don't you come in for a consult? And she has, as well as many other patients. And I think at this point, we're in the double digits for the number of patients I personally have been treating with oral JAK inhibitors for widespread or severe alopecia areata. Olumiant is a fantastic drug. It comes in 2 different doses, and it's dosed based on the severity of the alopecia, 2 and 4 milligrams. And here's an example of how the trial was done. This is a really long trial because it takes a long time to grow hair, which if you didn't know that, you can check out our Derm Bros lecture from a while back on hair. I think it was our last Halloween lecture.
Yeah, it was our Halloween hair loss harangue. wait, hey, what was her name? Stephanie Cook came. She assisted from Top Rank Boxing.
One of Dr. Greenberg's friends came and she did the introduction. But the way this trial worked is they started patients on drug. They were randomized to placebo or the 2 different doses, and they were followed out to 36 weeks. And they looked at a severity of alopecia score called a SALT score. And do we have a slide for that, Dr. Greenberg?
Let's see.
Looks like we
don't have that slide.
Don't. Oh, that's too bad. So all of the hair loss slides that I put in disappeared.
Well, hang on.
So you could have all of your Olumiant slides.
Those are fine.
That's okay.
No, I don't know where they went.
That's too bad.
Yeah, because the pictures for this are fantastic.
It's really amazing to see patients grow their hair back over time. It was really good we had all those safety slides for Vtama though, Doc.
Yeah, that's good. Just so you know, Vtama is safe. There's nothing to monitor. But this one, you do have to do blood work for all of the...
The take-home message is this. When they watch the patients in this clinical trial, I know it is getting a little, a little warm in here.
Sorry, it's a little hot.
So the take-home message, though, with this particular medication is when they watched patients essentially week to week, 2 weeks at a time, and took photos of their scalp all the way out to week 36, miraculously, they just watched hair regrow, and that's life-changing. We treat so many children and adults, and to suddenly go from having normal hair to having no hair can be very stigmatizing and marginalizing for a lot of patients. So I'm so happy that we finally have a medication on label for this disease that's historically been difficult to treat and required essentially toxic immunosuppressants.
Right. We've also, injected alopecia areata, and we're waiting on some of the topical JAKs and seeing if those work too. For alopecia areata, the mechanism's the same. It's just oral, injectable. Yeah. Well, it looks like you have about 100 slides on Cibinqo, a disease that I've seen maybe once in my
So this is an interesting disease state, generalized pustular psoriasis. It's quite a terrible disease to have, and I've treated a handful of patients. It's extremely rare. I've only treated 2 or 3 in my entire time as a dermatologist, but that's actually a lot more than most dermatologists.
Right,
As
I've
Dr.
treated
Greenberg
one.
is pointing out. And really, I think it's just random when they present. But I can tell you, patients with this, and if you're a patient who's ever had this disease, my experience has been it's severe, immediate onset, and explosive. And patients usually end up in an ER worried if they're going to die because all of a sudden their skin goes from normal to bubbling with pustules popped out all over. And it's kind of an emergency to treat it. And we used to have to use pretty toxic medicines like cyclosporin or acetretin to treat it. We finally have an on-label medication, which is Cibinqo, which is made by Boehringer Ingelheim. And it targets a specific cytokine that's been shown to be important in this disease state. And that's shown here as binding and inhibiting IL-36 signaling by inhibiting the IL-36 receptor.
Yeah, it's amazing that they even came up with this. I'm astounded. But it's a lot of work to get to this point.
It really is. It's a lot of work to get to a single drug that targets a single molecule. And what I love about Boehringer Ingelheim for doing this is this arguably is a very rare disease. This was a huge investment to be able to really deliver a drug to a patient population with an unmet need in dermatology. And this gives you an example of really how fast that it works. These are patients baseline week 1, week 4, and week 12, and we see rapid clearance in their pustular psoriasis. And this drug is given IV, so we usually need to do it in collaboration either with our inpatient friends or someone who has an infusion center, like our comprehensive cancer colleagues, or a lot of times I refer to one of our rheumatology offices in town, Dr. Kelly's office. I know
Sure.
Dr. Greenberg has an in-office infusion center. They've been very helpful for us.
This disease is about 1,000 times more common, acne and rosacea, and we see this, I'd say, about 20 times a day each, if not more.
Absolutely.
Super common, lots of new treatments for this, and sort of the inspiration for our slide here.
So, Twyneo. 2 things that don't seem like they'd go together, but when you put them together, miraculous things happen, right? Just like our friends Arnold Schwarzenegger and Danny DeVito.
Yeah,
Totally
me and Dr.
twinning.
Cotter.
And really, the secret sauce behind this, for the longest time in dermatology, the dogma was don't combine your BPO with tret. And the reason was because benzoyl peroxide will oxidize tretinoin, thus resulting in inactivation of that molecule. But Galderma has been able to license the technology that microencapsulates each of these medicines using silica microcapsules. And that does 2 things. It keeps these two drugs apart, preventing them from inhibiting one another, and then it also slowly releases them on the skin over time.
Yeah, that slow release is nice.
So what's really cool is we're using 0.1% tretinoin. When I have to prescribe generic tretinoin because that's the only thing the insurance will cover, I have to start, Dr. Greenberg, with tret 0.025%.
Yeah, this one's too strong. If you're doing a quick release, that's really going to bother somebody.
Exactly. You could never put tret 0.1% on someone's naive skin without giving them essentially chemical burn and having, a lot of harm from that. So we will do like tret 0.025 every other day for a couple of weeks until they get used to it. But with Twyneo, you can jump right in. And that's why it works so fast. Here's an example of a patient coming in with moderate moderate acne at baseline, and by week 2, he's improving really quickly. He's gone down from a pimple count of 72 down to 29, and by week 12, he's got 0 pimples left.
That's fabulous. I heard he has more friends now.
He definitely has more friends, and same for this guy here. You know, this is someone with really severe acne coming in. Maybe he's feeling a little self-conscious.
Sure.
You know, Dr. Greenberg, I know you recently just started back in the dating pool, you know, jumped on Hinge and Tinder.
No, that was pretty horrible.
You know, here's the thing, right? If this is you and you're getting into that space, you're not ready to swipe right. But 12 weeks later on Twyneo, he's swiping all day long. This is a happy guy.
Yeah, I think, you know, I had a mustache for a year and it really didn't do me very good, but I really enjoyed it. I don't know how this guy's doing on the dating apps, but maybe it's doing well for him. Yeah, Twyneo is nice to have that drug, and we're going to talk later about another encapsulated BPO. That technology has made quite a difference for people. So the topical options for acne also include, the standard of care had been topical retinoids, then topical antibiotics and benzoyl peroxides, but now there's a new class, and these are the androgen receptor inhibitors. According to the American Academy of Dermatology, whether you have mild, moderate, or severe depends on what you're going to get. And in our clinic, we do end up seeing some of the more severe cases. So we have written for quite a bit of isotretinoin.
I think I saw 8 or 9 patients today that were on isotretinoin.
Oh my God. Yeah, so that's Accutane. It's a federally regulated drug, and there's a lot to monitor. It's monthly doctor's visits, plus going online for a federal registry in order to get that drug. But with Winlevi, which is this androgen receptor inhibitor, it's clascoterone cream. What it does is it targets a different mechanism that we're not used to targeting. So by targeting this androgen receptor, you decrease oiliness. And if you look at these bodybuilders, and I had a patient the other day tell me that he's on testosterone and I should get on it too, and that really made me feel very good. Anyway, a lot of the bodybuilders get a lot of acne. And so, you know, in order to treat that, a drug like this may be an option for that type of person, as well as, you know, it's indicated for people 12 years of age and older, so for boys and girls or men and women.
I'm glad you brought up the testosterone usage, Dr. Greenberg. I see a lot of patients come in and they have sudden onset acne, and I just ask, are you taking these supplements or are you on testosterone? And I like to normalize it, because we're not here to judge, we're here to help. There's lots of men out there with low testosterone that are on low dose T to normalize, you know, lots of things. Brain fog, sexual function, muscle strength. There's also people that use it for other reasons to get big gains. And the reality is, talk to your dermatologist, let them know what's going on in the rest of your life so that we can help. There's no reason why someone has to have acne while they're on testosterone. I've had patients come in, you probably have too, and they're on 4 medications. I'll tell you the first, Dr. Greenberg, we'll see if you can guess the rest. They're on testosterone for whatever reason. And maybe they have a little bit of hair loss. So what medicine would they be on for that?
Oh, they're on Propecia.
Propecia. And then they get a little acne. So then they maybe get bad acne. So they get on.
Or Accutane.
And if it's really bad, they get on Accutane. Yep, that's the third one. But sometimes when you mix testosterone and Propecia, you start having some other problems.
And then they're on Viagra.
And then they're on Viagra. Yeah. So I tell all of my patients,
Cialis.
it's fine. It's part of life.
Sure.
There's better living through pharmacotherapy. So talk to your doctor. There's no reason to suffer in silence.
Yeah, and one other thing is, you know, some women are on IUDs that have levonorgestrel, and sometimes that can cause acne. I wrote a paper when I was at Texas A&M about that. Here's just showing the DHT and how it's reacting with the oil gland. And here, the androgen receptor, when it binds, when it binds that dihydrotestosterone, it leads to these cytokines that cause the acne. And here, when you use the Winlevi, it blocks that. So by blocking that mechanism, you don't get the acne buildup. And you can see how similar, you know, these 4 hydrocarbons are, you know, biochemically, how these all look the same. And spironolactone is a drug that we use a lot in dermatology for our female patients when they don't want to go on an oral antibiotic, for instance.
What's exciting about this medication is it's an entirely new class of topical acne therapy. And I'm sure you have patients that come in and say, I want to treat what's causing my disease. And that's always tough with acne because it really is the most common skin disease in the world. 85% of people experience acne at some point in their life. And I tell them, what causes your acne? Well, 1, being human, but 2, hormones. And we know that puberty makes it worse. We know that certain hormones, like the birth control you mentioned, Dr. Greenberg, can. So it's great to get at the molecular root and target the...
Right. So here the clascoterone is taking that binding site, and by taking the binding site, it doesn't allow the dihydrotestosterone to bind, and by not allowing that to bind, you don't get those effects. And that's, basically how all of the drugs that we've talked about, the IL inhibitors, are working by not allowing the ligand to go into that enzyme to cause that function to change. And here's just showing how it's metabolized in the body, and they did the studies to show that it was safe for people to use. And here's someone at baseline versus 12 weeks. And this young man was probably too young to go into the dating pool. He should just focus on his studies at this point.
What's the right age, Dr. Greenberg?
You have to ask your parent for that.
Birthday boy! It's Dr. Greenberg's birthday very soon.
Yeah, 21 again. All right, so the warnings, there's HPA axis suppression that may develop if you use a high dose, and that's going to be something that you're going to want to talk to your physician about and monitor. And here's your drug, the microencapsulation.
Well, I wouldn't say it's my drug, but I do speak for Galderma. I don't speak on this product.
Oh, you should.
It is a fantastic medication, and we've been prescribing a lot more of it. When it first came out, the idea of using benzoyl peroxide to treat rosacea seemed very foreign, because usually benzoyl peroxide is very irritating to the face, and when we use it for acne, the most common complaint I get is it made my face red, and that's the last thing you want to do in rosacea. But this idea of microencapsulation, allowing for gradual release, is really the secret sauce here. Let's take a look at some patient profiles, Dr. Greenberg. These are out of the clinical trials. This is a gentleman coming in at baseline, and this is 12 weeks later, monotherapy with Epsolay alone.
Yeah, I mean,
this is the type of thing.
That one's dead.
This is the type of thing we'd only see with oral antibiotics in the past.
Sure. So you have your inflammatory papules and pustules. This is quite an inflammatory rosacea case.
And here's another one. Here's a young woman with a very similar case, probably moderate to severe papulopustular rosacea, also with a little bit of redness, some ET rosacea, erythematotelangiectatic, all improving over a 12-week course with Epsolay.
Mm-hmm. Here's a topical minocycline foam approved for rosacea.
In the same space, working on rosacea, topical minocycline works really well over time. One pro tip, if there's any dermatologists or derm providers out there, you don't want to mix your topical minocyclines with a topical benzoyl peroxide. What ends up happening is that BPO will oxidize the minocycline and it will stain the skin black. Particularly, you'll get black pores because the minocycline foam is micronized and it gets right into the pores extremely well, but the benzoyl peroxide will turn it black.
So this one I was super excited about. Today's our filler Friday. We've been injecting Botox and fillers all day long. Well, I do mine in the afternoon.
I do it whenever you come in.
Yeah, well, fair enough. But here's somebody, they used, this one was Dysport, and you can see how the corrugators are coming in. But here, after having Dysport on board, but not doing the nasalis or the under eye area, the under orbicularis.
Yeah, I see this a lot, Dr. Greenberg, where we treat patients in certain areas and then they'll compensate with other facial muscles.
That's right.
So it's really important to get a full assessment and then target those areas, especially at follow-up if a patient is compensating. And you can certainly do Botox under the eyes and in the nose.
So we've been using these drugs for years. We've all been very, excited and happy about it. The patients come in, every 4 to 6 months just for treatment. But now, we have botulinum toxin, we have Dysport, we have Xeomin. All of these are great. In Nevada, we're typically using the 50-unit bottles because they're single patient use. But now there's a new one that's come out, and it's called Daxxify. Hello, when did she come on? I'm sorry, I didn't realize. She doesn't look like she needs anything, but...
Maybe it's because she's got neurotoxin in, Doc.
She got neurotoxin. It's the type of thing where people don't necessarily tell you that they have it on board. You just find out later. Daxxify is a longer lasting botulinum toxin. So it'll be nice for people who know that they like the look and they would like to not get as many injections.
Yeah, maybe come a little less frequently.
The interesting thing is with this injection, and I have a patient who is allergic to albumin. And albumin is it's a protein and it's found in eggs. And a lot of the products that we use for injectables have albumin in it. This one does not have it in it. She's albumin allergic. She can't do Botox, but she could do Daxxify because there is no albumin. So this is allowing for the formulation without that. And it can be stored at room temperature. The way that it's drawn up is going to be similar. We haven't done this injection yet. We need to get some samples to test it out on our patients. but it's already approved. And here at 24 weeks, they're just now starting to come in. I usually tell my patients with Botox, 4 to 6 months, and I say the same thing for Dysport.
I usually tell my patients it's 2 to 3 months for Botox. I feel like the on-label dosing is 3 months if you do FDA-approved dosing in the glabella and the crow's feet, and off-label in some other areas. But it's all about the dose. So if you get enough tox, it may last longer. So it depends on how you're putting it in, Doc.
Well, also, I agree that the amount of drug, because they're 50-unit bottles, as we divide it over 3 areas, you may not get a complete result.
Exactly.
And this slide here, and I have to thank Jessica for this slide, just shows that over time, the effects wear off. But here at 16 weeks, 70% of people still have drug on board. That's 4 months. 5 months, more than half of the patients. So it's something to look out for as we move forward. And here we have our wrinkle reduction. In terms of, yes, we had the injectables for botulinum toxins, and these are fillers. Fillers are great. Today I did some Restylane Kiss. Restylane Kiss is one that I like for the lips because it's a little bit thinner.
It does look nice in the lips. It makes for a nice, luscious, kissable lip.
It's good. What did you inject in mine? You gave me a Juvederm, right?
I think you were a little nervous when you did your lips. So we were really thin with Dr. Greenberg. We did half a syringe of Volbella. I think that you could do well with maybe either we could try some Restylane Kiss. It'd plump you up. We could give you a little more structure and do something like a Juvederm Ultra. I think you can't go wrong, Doc.
Yeah.
Are you going to let me inject you again?
Yeah, I think I would do it. It's been a while, and this was this is just showing the different sizes. So the different products have different sizes and different thicknesses to the product, and that will really affect where you inject the product. And this is one of our assistants, and I didn't think she needed anything, but she wanted some Restylane Kiss in her lips, and what I did was just very superficially injected.
It looks nice. It's still a natural result. Her lips look more plump, more moist.
Yeah, she's happy with it. So, that's what counts. And these were some patients who we did with Juvederm and Restylane, and this one was more of a lip lining, just to more define the lip, and this one was a lip bulking. So each one, there's different styles, and I think I inject with different styles depending on what the person wants. I'm sure you do the same.
Honestly, if you're watching this and you want to come to me for your lips, I'll tell you right now, I like to do a really natural lip. And if you want something different than that, maybe a different provider or a different doctor. Dr. Greenberg will make your lip look exactly how you want. And I just like a natural lip because I feel like if you're walking around town and someone says, "Who did your lips?" And you say, "Oh, it's Dr. Cotter," and they think your lips look crazy. Well, I don't want to be part of that.
Yeah, one of our pharmaceutical reps had gotten 3 syringes of filler in her lips, and it looked totally unnatural, but she was happy with it.
She was happy. Yeah.
So it's what everybody wants. And here's where your other slide went, the hair loss slide. So hair loss is super common. So this is going to be your Olumiant slide, which got sort of moved around.
Is that right?
For the
great.
Alopecia areata. But we see a lot of hair loss. Male pattern hair loss is one of the most common things we see in our practice, and we've been doing PRP. And if you want to learn more about hair loss, that Halloween hair loss harangue has everything hair loss.
It really is a fun one. I think Dr. Greenberg is injecting me with PRP live.
Yeah, with a mohawk.
Video. Yeah, he's got a mohawk that night.
Yeah, that was fabulous.
It's worth a revisit.
Yeah, and here somebody's being injected for alopecia areata. This is typically where we use the catalog.
Oh, I'm so glad these slides are coming up. I'm so happy right now.
And here's just talking about how many hair follicles the body has, which is a lot. And that's, those hair follicles are important, especially, I didn't get into it with the vitiligo indication, but with vitiligo, having those hair follicles allows for some of those melanocytes to come from the hair follicle to improve that condition.
We usually see the color coming right around the hair follicles.
Mm-hmm. And here's your
oh yeah. Let's look at the before and afters, the treatment responses, because it's amazing. So here's an example of the SALT score. Right? This is a SALT 100. This is a patient with 0 hair on their scalp. And then over time, we get down to like a SALT score of 1 with increasing coverage. And it's based on the severity of alopecia in each area. Let's look at patients on drug over time. And so we see patients that start with pretty high SALT scores. SALT score of 98, SALT score of 89. And as we march forward from baseline to week 12, which to translate is really 3 months. Okay, so at 3 months, there's a lot of hair regrowth, but there's still more work to be done. Fast forward to week 36, so about 9 months later, there's almost full coverage. In this case, there is full coverage, and here it's a SALT score of 3. So about 97% improvement. Incredible.
Yeah, these are life-altering drugs. And, I had tried to get a patient approved for Xeljanz. He was a professional athlete and wasn't sure he wanted to go on it. But now that I have more familiarity with JAKs, and now that there's something FDA approved for it, this would be the drug for
This is a
that
patient on the
person.
2 milligram dose.
Wow.
Here's some results on 4 milligrams. And really the package insert gives doctors the flexibility to prescribe either the 2 or 4 milligram. I personally, Dr. Greenberg, I've been using the 4 milligram in patients with more severe or widespread alopecia areata. And one of the markers I've been using is either a totalis phenotype or at least loss of eyebrows and eyelashes, because those are historically a little more difficult to treat. And it's very stigmatizing to not have your eyebrows or eyelashes. And here's some examples of 4 milligram doses.
This is
just absolutely amazing.
I think I'd probably lean more towards starting at 4 because I think the results are better. Yeah, here you go.
This gives you an idea of kind of who does what over time. And we've got about 40% of patients having a SALT score less than 20 on the 4 milligram dose and about 20% on the 2 milligram dose. For SALT score less than 10, it's 15 and 30. Oh boy.
This was a while back, but while we were beginning our training. I missed Kim. She wasn't here today, our medical assistant, but she was asking about fighting. And certainly Dr. Cotter is a black belt in Taekwondo versus me is taking 2 lessons. It makes a difference. So that was a different slide. This one, I think we're missing the one slide. And yes, thank you everybody for watching. But we did want to talk about our foundation. We did start a charitable foundation during the pandemic.
It really has 3 primary missions, and they're all centered around dermatology, both for education and for outreach. So one of the things we are both extremely passionate about and work with the medical students at UNLV and some from other medical schools, as well as the residents. We have residents in our clinic often writing case reports and doing research with us, is dermatologic educational support. So having one pillar of the charity for things like grants, research support, fostering education for people that want to continue on in dermatology, whether that's a medical assistant that wants to go on for more education, or a medical student that's applying to dermatology, or someone that needs a research project funded.
Yeah, and we're going to do, we're going to have some events. We haven't had any yet. We just got the approval this year. So as we work through it, we're going to be doing different events around town, and we're going to have speakers to talk about skin disease, and we're going to offer treatments for people who can't afford treatments.
Yeah, so the idea behind bringing in speakers is community education, bring in national or international thought leaders, or even inspirational speakers to come in and talk about dermatology or dermatologic conditions, or maybe inspirational speakers with certain diseases to come in and create support groups for our patients with these diseases. One of the other community outreach things that we feel strongly about is sun protection. Getting sunscreen at parks and professional sporting events and sun shelters at schools. And sometimes we may be able to partner with the American Academy of Dermatology to get sunshades out there in the community.
Yeah, so, stay tuned. There's a lot that's going to be going forward with this. Look, it's been almost a year since we were last here. We were just happy to get back together. We're happy that all of you survived the pandemic. It's been a really difficult time for everyone. But, we've got these poker chips now. So we are going to do a giveaway. So if you're a super fan, we've got some socks. And we made some Derm Bros socks during the pandemic. You can just toss them and I'll catch them. Or not, I'll grab them. Okay. We have the classic blues and yellow, our Michigan colors here.
I really do like the yellow with the black scrubs.
Yep.
The blue are great, just all around town anytime.
And the We Wear Pink on Wednesday socks, where Dr. Cotter and I are riding camels for hump day. And we'll be giving away these socks to 3 super fans.
Let's see. I love these socks because they're pink for Wednesday. We're riding camels, but even in our cartoons, I still won't wear pink scrubs.
Yeah, that's right. He's wearing the black scrubs. Every Wednesday, I'm always hopeful that someday I'm going to come in and he'll be wearing his pink scrubs. We've got on my TikTok channel a little ode to it, and on our Derm Bros Instagram channel, we've got something about it. But stay tuned, because sometime, this man may wear a pink set of scrubs. The whole staff wears pink. That's a Mean Girls thing on Wednesdays. But that's that. And I don't know, do you have any other parting words?
Cheers.
Cheers. Derm Bros 13. All right. Wow, I can't believe it.
Nice work, man.
Yeah,
that was good.
That was good.
That was fun.
Yeah, I think